Texas town of El Paso, I fell in love with a Mexican girl. Nighttime would find me in Rosa's cantina, music would play and Felina would whirl. Blacker the night were the eyes of Felina, wicked and evil were casting a spell. My love was deep for this Mexican maiden, I was in love but in vain I could tell.
Bring it on home now. Bring it on home so we can get out of here real earlier. I know our speaker, we usually have several speakers when APS holds an event. And the doctor's been on his feet all day. I feel for him, but he sure is rock and rolling. He's doing a great job. Just for me, I want to let you know I've had many comments on how great speakers you are. They want to welcome you to El Paso. They want to welcome you back to speak at any time. So we get everybody to have a seat real quick. You know, we can't put on a conference like this without people who are helping us every day in the community. APS realized a long time ago that we don't work in the vacuum. And I think it's been a great event because we have many partners that serve on the committee that actually helped put this on for our community after the University of Texas San Antonio Health Sciences Center contacted us. For my staff, I want to recognize Felix Cabrera. Any of you know Felix? Grace Ortiz. Administrative assistant taking the photos over here, Maricela Lopez. Say hi, Marty. That's a nice staff. And I would like to recognize people who served on the community and the organizations they're from. We have Hector Yanez from Lifespan. Are you still here? Lisa Barrio Cox from AmeriGroup. Come on up here, Lisa. Oli San Roman from Caprock Home Health. Caprock. Thank you for keeping me straight there. Caprock's temple. Deve Leva from Sunridge Assisted Living. Michelle Salinas from Bien Vivir. Laura Nemham from Humana. Is Michelle still here? Ana Olivares from Texas 211. Come on up here, Ana. Mary Lou Alcala from Vista Hills Dental. Oscar Sotelo, UC sign says UVH. They recently changed their name to El Paso Behavioral Health Systems.
We might get out early.
And Susana Vargas from Alzheimer's Association could not make it today. We want to recognize them also for their part in this. And a special recognition from Mr. Rick Rosso here from Region 19 Education Service Center. Mr. Rosso and his staff have been great hosts for us, and we certainly appreciate providing this menu at no charge to us. As you see, the professional community that's out here really appreciates it. And all the University of Texas San Antonio Health Sciences Center appreciates it. Thank you for every opportunity. Thank you very much. Thank you, sir. They want to take let's take a quick photo, and then we'll draw for two more prizes.
Right in front of the alcohol slide. Yeah, we made you in front of the
Mr. Turtley. I love him.
074, 74.
Oh,
I have a winner. This next legal aid for 092, 92, 092, and we have a winner. Congratulations, stay tuned to the end of our grand final.
all right. 3 down, 1 to go. Okay. Talk about alcohol. Right? Yeah, we need a drink. Right? Okay, so here we go. So we're going to talk about the epidemiology of alcohol use disorders in the elderly. We'll talk about the effects of alcohol use disorders on organ systems, including organ system diseases, including dementia, cardiovascular disease, liver failure, cancer. We'll talk about screening questions for use with alcohol disorders. Spend quite a bit of time on just quantifying, helping quantify alcohol consumption when you're taking alcohol history. And then we'll also talk about the morbidity and mortality of alcohol withdrawal, and talk about pharmacological management of alcohol. So, towards just basic epidemiology, about 50 to 60% of older adults are abstainers. So abstinence is defined in multiple ways. It's probably most commonly defined as, have you had a drink in the last year? So 50 to 60% of elders will state that they have not had any alcohol at all in the past year. About 15% will screen positive or at risk or problem drinking, and we'll talk about what problem drinking is. 30% have a lifetime history of alcohol abuse or dependence. And so, so alcohol use is common. 15% are screening positive for current at-risk or problem drinking in their older years. And so 30% have a lifetime history of alcohol abuse or dependence. What is the difference? What is the difference between alcohol abuse and alcohol dependence? What's the difference? Abuse and dependence. Use or abuse? What's that? Use or abuse? Okay. Now, what's the difference between abuse, alcohol abuse, A-B-U-S-E, abuse, and dependence? So dependence, you need to be drinking every day. Okay, maybe, could be, yeah. Okay.
Abuse might be every weekend getting plastered.
Yeah. Good, yeah, so the example that was said was that for people who are dependent on alcohol, they essentially need it every day. They have withdrawal symptoms if they go without it, whereas an example of abuse might be, I think to use your words, getting plastered every weekend, but not getting plastered Monday through Thursday. Right? Okay. So or something like that. Okay. So that's exactly right. So when we think about alcohol dependence, the two hallmark features of dependence are going to be tolerance and withdrawal. Right? So tolerance. So when people are dependent on alcohol, their physiology has changed. It's changed the way their body works. And so the first manifestation of the change is that they become tolerant. They require more and more and more and more alcohol to get the desired effect, right? So it's no longer one beer is sufficient or a six-pack sufficient or however many. They require more alcohol to get the same effect. That's tolerance. And then withdrawal is that if they were to stop drinking, their body will have a physiological reaction to that, and they will have all these side effects as they come off of the drug, right? They'll have all these bad side effects as they come off the drug. That's dependence. Whereas abuse, people don't have the tolerance yet, they don't have the withdrawal perhaps, but alcohol is creating problems in their lives, right? So they might have, for example, they might have a DWI or a public intoxication charge. They're not hooked on alcohol. They were drinking more than they should have been, and it led to this impaired function. They get plastered, as you're saying, perhaps on the weekends, like college frat parties or whatever, right? Or not. And so it's just kind of, the alcohol intake is sufficient to cause disturbances in their social, occupational functioning, but not necessarily their physiological function, at least yet. Right? Okay, so what's that? Oh, you like that? It kind of makes you thirsty. Is that? Yeah. This is like totally not fair. Okay, so yeah, it does look fun. Right. So when taking an alcohol history, what question do you ask first? So if you're asking your patients about alcohol, what do you ask first? How often do you drink? How frequently do you drink? Yeah, so typically, probably the question I ask most often is just, how much do you drink per week? You know, how much alcohol do you drink per week? Do I ask, do you drink alcohol? No, I don't ask that question. The reason I don't ask, do you drink alcohol, is a lot of times the patients will perceive that I'm going to judge them if they say yes. I don't want to mess around with that. So if they don't drink alcohol, they'll say, well, I don't drink any alcohol at all each week, right? But I always kind of go in when I'm interviewing a patient, I just assume that they are, and just to kind of eliminate the judgment, I just will ask them, how much alcohol do you drink per week? Right? So that's how I do. Try to be very matter-of-fact, very non-judgmental. How much alcohol do you drink? What question would you ask second?
What do you drink?
What do you drink?
How often?
How often do you drink? Okay. I always ask what size are the cans, right? So, or try to start to get kind of quantified here, right? So a lot of times for my patients, they'll say, well, I drink, whatever, 2 or 3 beers a day, right? They might say they drink 2 or 3 beers a day, and in my mind, I'm thinking 2 or 3 12-ounce cans. But what I've come to learn over time is that there's all sorts of ways to package alcohol, and so I always ask them what size are the cans, or try to get a little bit more information about the actual quantity that they're drinking. 3 or 4 drinks per week. If they're drinking liquor, then I might ask, how long will a bottle last them, or something like that. How long will a fit last them? What question would you ask third? So you'd ask them how much they drink, what size are the cans, what would you ask third?
What do you drink?
What are you drinking right now?
Beer, wine.
Beer, wine, liquor, maybe? Yeah. I always ask, when was your last drink, right? The next question I always ask is, when was your last drink? You can imagine that when I'm doing these APS consults, these capacity assessments, I don't want to be evaluating people when they're intoxicated, right? Sometimes I have to. But in general, we want to know kind of how long have they gone without alcohol. And that always gives me a sense of, I start to get a sense of if they're, if they have no alcohol history, or if they might be vulnerable to dependence, or if they might be vulnerable to abuse. So if it's 11 in the morning, I say, well, when was your last drink? And they say, well, I had a beer this morning. Well, that kind of tells me that, okay, well, that's not within the social norm, so I have to follow up on that. When was your last drink becomes incredibly important is when you're judging the risk of alcohol withdrawal. And we're going to spend quite a bit of time, we're going to spend time talking about alcohol withdrawal delirium, and why when was your last drink is such an important question. So if you start to think about alcohol, we're going to talk about alcohol quantification. Whenever I talk about alcohol, what I find among the audience is that some audience members know a lot about alcohol. And some audience members don't know much at all. So I like to kind of get us all on the same page, at least with alcohol quantifications. Right? What's that? No, not you? Not here. Okay, not in El Paso. Maybe it's San Antonio. So when you're taking alcohol histories, we can start to think about quantifying alcohol. But alcohol essentially comes, we're going to talk about beer, wine, and liquor. So when I talk about beer, I'm talking about a 12-ounce can of beer. Okay? I know alcohol comes in 24-ounce or even bigger, sometimes smaller. But I'm talking about 12-ounce cans of beer. So just starting right off with alcohol, with beer, patients will quantify it as they drink a six. They'll tell you how long a 6-pack will last or a 12-pack will last. They'll go to a specialty store for the 18-pack. Sometimes for my medical students, they get confused with the idea of a case and a 12-pack. So, a veteran will tell them they drink a case a day, and the medical student will assume that a case is a 12-pack. But a case is not a 12-pack, it's 24 beers, right? So a case is 24 beers, not 12 beers. I hear you chuckling in the background. So we're talking about 12-ounce cans of beer, 6-packs, 12-packs, 18-packs, 24-packs. Okay, so when patients are drinking liquor, for liquor, I'm going to talk about what is the standard brew of rums, whiskeys, tequilas, vodkas. What's the standard brew? Most common is what? 80, right? The most common proof, 80 proof. If something is 80, what does it mean to be 80 proof? What is that? What?
Drunk.
Drunk. So what does 80 proof mean? So if something is 80 proof, it means that it's 40% alcohol by volume, right? So the proof is double the percent of alcohol by volume, right? So I'm talking about, so your standard, you go to a liquor store, you just get most of the bottles of vodka, tequila, whiskeys, rums, most of them are 80 proof. There is variance, right? So there is variance. So whatever, Sailor Jerry's is going to be 92 proof, and if you like the lime citrus rum, it's going to be whatever, 70 proof. So there is variance in all of this, but standard proof is 80 proof. So I'm talking about 80 proof liquor. For patients are drinking liquor, what is the quantities that they'll use to describe the volume of liquor that they're drinking? What are the terms they use? A shot. How much is a shot? How much? 1.5 ounces. That's right. 1.5 ounces. Right? An ounce and a half is a shot. So they might say they drink a shot. What else might they say they drink? How else might they quantify it? A liter. You might say they drink a liter. What else?
A pint.
A pint? Probably most commonly would be like a fifth. Right? So have you ever heard? I drink a. They'll drink like a fifth. I drink a fifth a day, right? So have you ever heard that term? They'll say that they drink a fifth. So a fifth. So what is a fifth? When they say they're drinking a fifth, what is that? What is it a fifth of? Huh? No. It's a fifth of a gallon. Okay, so a fifth is 750 cc's. Okay, a fifth is a fifth of a gallon, which is 750 cc's. So in your mind, in your brain, you can picture a bottle of wine. Just picture a regular bottle of wine, not the bonus bottle, not the box of wine. Just picture a regular bottle of wine. A regular bottle of wine is 750 cc's. That's how much a fifth is, a regular bottle of wine. Nobody ever says they drink a fifth of wine. That would be weird. But for liquor, you will hear that they drink a fifth a day, or you can ask them how long a fifth will last. So a fifth is 750 cc's, which is the same amount of alcohol as in a regular sized bottle of wine. So drinking 750 cc's of 80 proof liquor is the same as drinking 18 12-ounce beers. So 18 12-ounce beers has the same amount of alcohol in it as a fifth of 80 proof liquor. And then you can adjust accordingly. So a shot, which is 1.5 ounces, a 1.5 ounce shot has the same amount of alcohol in it as a 6-ounce can of beer, which has the same amount of alcohol in it as a 5-ounce glass of wine. Okay? So 12 ounces of beer has the same amount of alcohol as 5 ounces of wine, which has the same amount of alcohol as 1.5 ounces of 80 proof liquor. So if they're drinking a pint, so someone over here said they might say they drink a pint is the same as drinking a 12-pack of 12-ounce cans. A fifth is the same as drinking 18. A liter of 80 proof liquor would be the same as drinking a case. Have you ever heard the term handle? So drink a, nobody, I've never had a patient drink a handle a day, but they'll tell me how a handle will last them 2 or 3 days. Do you know how much a handle is? 1.75 liters. Okay, so if you ever heard the term handle, it's 1.75 liters. I've never had that, but what's that? Whiskey? Yeah. A handle, it's a blend, it's a 1.7. And so then with wine, it's easy. It's just 1 bottle of wine, 2 bottles of wine, 3 bottles of wine, 4. Okay, so drinking 1 bottle of wine, and again, just a regular bottle of wine, not the bonus liter bottle, not the box or the cube, or I don't know if there's a triangle, there's probably a triangle. So the 1 bottle of wine is the same as 6 12-ounce beers, which is the same as 6 1.5-ounce 80 proof shots. Okay? So as you're talking with patients, if they say, well, I drink a fifth a day and a 6-pack, what that tells you is that they're drinking the equivalent of a case of 24-ounce beers. Okay, so now you can start to kind of quantify the amount of alcohol they're taking, because most people can relate to how much alcohol a 12-ounce can of beer is, and you can kind of in your own mind estimate or appreciate, I should say, the volume of alcohol intake of the person you're talking with is consuming. Okay? So what is the legal limit in Texas? What is it? That's legal limit? 0.08, 0.08. And so the legal limit is 0.08. But if you've ever worked in a hospital setting and alcohol labs are drawn, do you ever see any number that looks like 0.08? What would you see instead on hospital lab records? You won't see 0.08, you'll see what? 80, right? So 0.08, the unit is 0.08 grams per deciliter. But hospital labs, most medical labs, quantify it as milligrams per deciliter. So it would be 80, right? So 0.08 is the legal limit in Texas. 0.08 grams per deciliter, or 80 milligrams per deciliter, is the legal limit in Texas. How many drinks does it take young adults to get to that limit? How many drinks in an hour? 3 or 4? 4? 2. Yeah, 2. Yeah. So so men are different from women. So here's where metabolism varies. So men are different from women. Eskimo men are different from Asian women who are different. So everybody's different, and there's a lot of difference really based on ethnicity. There's a lot of ethnic differences in the rate of alcohol metabolism. But in general, on average, consuming 2 drinks within an hour gets the average person, if you will, to 80. That's right, 2 drinks in an hour. So how many drinks does it take older adults to get to the legal limit? And is it different? How long does it take an 80-year-old to get there? Maybe 1. So you just think it might take fewer drinks? Why would it take fewer drinks? Because depends on their body habitus. It depends on so many variables, but in general, their liver just functions less efficiently, so they metabolize slower, and so it takes fewer drinks to get elders to the legal limit is why. So then we can think about sobriety. So how long does it take to get sober? Because that's what you really want to know, right? You want to know, how long am I going to have to hang out at the bar drinking coffee until I can drive, right? That's the question we're asking. Okay, so if someone has an alcohol, so say someone comes into Say someone comes into the hospital. So the classic scenario that we see every night at a university hospital is someone, they've gotten a fight with their girlfriend, they drank a lot of alcohol, they cut themselves, the police were called and they were taken to university hospital, and they have a blood alcohol level of 350. And now we have to wait for them to sober up. So if someone comes in with a blood alcohol level of 350, and we're not comfortable doing a psychiatry interview till they're sober, till their alcohol level has dropped to 50, how long is that person going to sit in the ER sober enough? How long?
What is the points of power going down?
Yeah, that's right. Very good. So then the question is how many blood alcohol level units? You're right. How many blood alcohol level units do you metabolize per hour? Right. That's what you need to know. And so you metabolize the same amount per hour, regardless of how much you start with. And the number, the magic number for, again, average people, everybody's different, so the average person is going to metabolize about 25 blood alcohol level units per hour. That's exactly right. So if someone comes in with a blood alcohol level of 350, and we can't do anything with them until they're sober, and they drop down to say 50, 350 minus 50 is 300, divided by 25 is 12. They're going to sit in the emergency room for 12 hours getting sober, right? So you want to know why emergency rooms, county hospital emergency rooms are so backed up. One of the reasons is it's sitting there waiting for the patients to sober up. So it's about 25 units per hour. So if you go to a bar and you have however many, 4 drinks or whatever, and your blood alcohol level then becomes 150, and you need to kind of get ready to drive, you're going to, 25 units per hour, you're not really safe to drive for about 3 hours, right? So you can kind of do the math in your own brain and appreciate how long it takes to achieve sobriety. So again, the legal limit in Texas is 0.08, which is the same as 80 milligrams per deciliter. It takes 2 to 3 drinks in an hour, depending on your gender, age, and weight. For most people, it's much closer to 2 drinks in an hour than it is to 3. How long does it take the body to achieve sobriety? So we metabolize 25 units per hour. So again, if you have a blood alcohol level of 200, and you're waiting to get down to 50, there's 6 hours that you're going to have to wait to get there. Okay, so we can talk a bit about alcohol metabolism. So alcohol is mostly metabolized through the liver, mostly excreted through the liver. Where else, though? How else does alcohol leave your body? So it gets metabolized through the liver. How else, though?
The bladder.
Huh?
Urinating.
Well, yeah, that would be kind of through the, that would be through metabolism still. How else?
Perspiration?
Perspiration. Have you ever smelled enough? Like where you can smell the alcohol leaving their pores, for example, for big heavy drinkers? There's kind of one more common way.
Breathing.
Not vomit, but breathing it out, right? So you breathe it out. So you never vomit. Okay. I'm assuming you don't vomit. Rookie. Okay, so assuming you don't vomit, no, through the breath. So that's how breathalyzers work, right? So, and you'll see people who are acutely drunk will be trying to breathe the alcohol out of their system, and you can smell it, right? So but most alcohol is metabolized through the liver. So alcohol is metabolized through the liver to become acetaldehyde, and then there's another enzyme steps in and metabolizes acetaldehyde to acetate. Acetaldehyde is a very toxic chemical to the body. Acetaldehyde is a very toxic chemical to the body. And so there are medications that are acetaldehyde dehydrogenase inhibitors that cause the body, that prevent this second metabolic step, the acetaldehyde to acetate. So this is how anabuse works. So you've heard of disulfiram or anabuse, medications that people might take to not control their drinking, but to encourage them not to drink. So if someone's taking Antabuse every day, it's a medication that they can take every day, and if they drink alcohol, it'll prevent the conversion of acetaldehyde to acetate. Acetaldehyde will build up in their system, and it's very toxic. They become very flushed. They start to perspire. They feel incredibly sick, and it's just an incredibly uncomfortable feeling. So it becomes a sort of an operant conditioning model of discouraging alcohol intake. So alcohol is being metabolized through the liver, and as people age, the metabolism just naturally slows down. It just naturally slows down. Okay, so we can talk about elders metabolized. So older adults have increased sensitivity to alcohol, that's established. Decreases in body mass. So because they tend to have decreased body mass, it increases in alcohol concentration within the tissues. And then there's interactions between alcohol and multiple over-the-counter and prescription medications that also decrease metabolism. So a lot of times elders are taking medications that specifically slow down the metabolism of alcohol, right? So there's all these different cytochrome P450 systems that just get slowed down or inhibited by their medications, thereby making them even more vulnerable to alcohol intoxication. All right, so the National Institutes of the NIAAA, NIAAA, this is the branch of the NIH, National Institute of Health, that specializes in alcohol-related research. So NIAAA recommendations for elders are that they have no more than 1 drink per day and they have no more than 7 drinks per week. So when there's all of these studies on alcohol use and problem drinking or at-risk drinking, this is commonly how they're characterizing this. Are they going above and beyond the recommendations of the NIAAA? So again, for elders, no more than 1 drink per day or no more than 7 drinks per week. Anything above this it's not necessarily problem drinking, but it's at least at-risk drinking. Okay, it may be a problem, it may not, but it's at least a risk factor. So then we can talk about screening questions. So talking with alcohol, talking with patients about their alcohol consumption, there's a whole lot of screening questions out there. And most of the good ones, again, they try to implement just a very matter-of-fact, non-judgmental approach so that you can get as much information out of your patients as you possibly can. So examples of questions, this is the Michigan Alcoholism Screening Test. So when talking with others, do you ever underestimate how much you actually drink? Are there ever times you underestimate how much you drink? After a few drinks, have you sometimes not eaten or been able to skip a meal because you didn't feel hungry? And I'll see that in elders quite commonly, where they're neglecting their overall nutrition, and the only nutrition, for lack of a better word, the only calories they're getting is from the alcohol. So when you think about calories per gram, so to put it in perspective, protein and carbohydrates have 4 calories per gram, fat has 10 calories per gram, and alcohol has 7 calories per gram. So alcohol has not quite as many calories per gram as fat, but certainly more than carbohydrates or proteins. Other screening questions, does having a few drinks help decrease your shakiness or tremors? Does alcohol sometimes make it hard for you to remember parts of the day or parts of the night? Any of your parts at all? Do you usually take a drink to relax or calm your nerves? Do you drink to take your mind off your problems? Have you ever increased your drinking after experiencing a loss in your life? I'll ask that question quite commonly. Has a doctor or nurse ever said they were worried or concerned about your drinking? Have you ever made rules? This is another thing I'll see. Have you ever made rules to manage your drinking? Right, sometimes I'll ask that. Well, okay, the rule is you never drink before 5. That's my rule. And another rule is that I'm going to drink a glass of water in between the drinks. And mind. So there's always kind of funny rules that people will come up with. And if you have a lot of rules to govern your drinking, it suggests there may be drinking issues. Right? More rules you have, and then when you feel lonely, does having a drink help? That's the last screening question. When you feel lonely, does having a drink help? So these are, this is just kind of common alcohol type screening questions. The Michigan alcoholism screening test. Very easy to give to patients and to talk to patients about alcohol. And so there are risk factors that are unique to elders. When it comes to alcohol, there just are these risk factors unique to them. So one is they just have increased free time, right? So what does it matter if it's before or after 5, right? Or what does it matter if it's before or after noon, right? I mean, time is time, and so they have increased free time. There's no difference in a Saturday. You kind of talk about getting plastered on the weekends, but when you're an elder, a Tuesday may be the same as a Sunday, right? Or a Saturday or a Friday. So kind of increased free time. A lot of them have increased disposable income, so they just have the money now to purchase the alcohol. Increased death of loved ones, and we know that bereavement is a risk factor for problem drinking. So increased death of loved ones. And finally, less social responsibilities. If you don't have to set the alarm in the morning, you can sleep in. What does it matter? You're not having to do, kind of the nuts and bolts work of your, career life. So less social responsibilities. So between the free time, the income, sort of the risk factors of increased death of loved ones, less social responsibilities. These are just a kind of unique set of risk factors that elders have to overcome. Sometimes you might hear about, well, maybe alcohol is good for you, right? Maybe you've probably heard this in the news, right? You may have heard that, well, alcohol may reduce cardiovascular disease. It might lower your risk of dementia. There may be some cancers that you're less vulnerable to. So sometimes people, patients in my clinic will say, well, I've heard that drinking a glass of red wine every day is good for you. I've heard that's good for you. So the problem with these studies about the beneficial effects of moderate, the problem with these studies is that all of the studies are generally limited to men, right? Only men are in these studies. And what has becoming so clear is that the risk of alcohol for breast cancer is, seems like every week there's a new study showing that alcohol increases the risk of breast cancer. So any studies that have shown benefit have generally been limited to men. And the second issue is that any studies that have shown benefit have generally been limited to middle-aged persons, right? So drinking a glass of red wine a day lowers the risk of heart attack in people who are in their 50s, for example, right? But these same data don't hold for elders, right? So there haven't been any studies that have shown that elders who engage in moderate drinking have health benefits. It's only been for people more middle-aged, and never for women. It's only been. And what is certainly known is the detrimental effects of drinking in elders. So we know that elders who are drinking are more prone to pancreatitis. If anybody's ever had pancreatitis, they'll be able to attest that it's just about one of the worst pains you can ever in your life experience. So pancreatitis, cirrhosis of the liver, cirrhosis of the spleen, cardiomyopathy, it enlarges the heart, it makes it less able to function, it leads to high blood pressure, it increases the risk of trauma, so you're more likely to fall over and smack your head when you're drinking. It increases the risk of dementia, and we'll talk about that. It increases the risk of depression, sleep disturbances, and then malnutrition and vitamin deficiencies. A lot of times with my elders, the ones that do, in my clinic I actually don't have a whole lot of alcohol-dependent elders. And the ones that do drink, tend to drink heavily, are the ones who say that they take it for sleep. Those are the ones that, I will have patients who say, for me to get any sleep at night, I have to drink a bottle I have to drink a bottle of wine to fall asleep. So the problem is that what alcohol does well is it can put people to sleep. There's no doubt about it. Alcohol can induce sleep. The problem is that as alcohol is metabolized, those metabolites are actually stimulants. So then what happens is you may fall asleep really quick, but then a couple hours later, you're up the rest of the night. It's just this constant, this very fragmented sleep as the alcohol is being metabolized out. So while it may induce sleep, it doesn't keep people asleep, right? They wake up throughout the night and they have this very fragmented sleep and they feel poor the next day. Okay, so now we're going to shift to alcohol withdrawal delirium. And the reason we talk about alcohol delirium is there's only 3 drugs that kill you on the withdrawal. Every other drug kills you on the intoxication, right? So there's only 3 types of drugs that kill you on the withdrawal. So what are those? Alcohol. Alcohol again. Beer, wine, and whiskey. Yeah, right. So alcohol, good. So alcohol, benzodiazepines, which are the anxiolytics, which are Xanax, Ativan, Valium, clonazepam. So alcohol, benzodiazepines, and barbiturates kill people on the withdrawal. They can also kill people on the intoxication, but they more commonly are killing people on the withdrawal. Okay? All the other drugs, cocaine, heroin, amphetamines, whatever, all the other drugs will kill you on the intoxication. But nobody has ever died of cocaine withdrawal. Right? You don't die from cocaine withdrawal. You wish you would be dead from heroin withdrawal, but heroin withdrawal doesn't kill you either. Okay? So the drugs that kill people on the withdrawal are alcohol, benzodiazepines, which is the Xanax, the Ativan, the Klonopin, the Valium, and barbiturates like phenobarbital, probably most common. So delirium secondary to alcohol. This is commonly known in the sort of in the everyday language as DTs. So you'll hear people say that they've had DTs or they suffer from DTs. But you might ask, have you ever been hospitalized for DTs? So what does DT stand for? Delirium tremens, that's right. So DT stands for delirium tremens. So delirium tremens is sort of the everyday language of delirium secondary to alcohol withdrawal. Okay, the everyday language. Talked a little bit, y'all remember, what's the mortality rate for alcohol withdrawal? If someone goes into DTs or alcohol-induced delirium, what percentage of them die? 20%, yeah. So the mortality rate from alcohol withdrawal delirium is 20%. That's high. I think that's high, right? 1 in 5 people who are alcohol dependent and have serious alcohol withdrawal and go into a DT state will have a will die. And that number has remained steady for years. And I think you would think that with improved recognition and improved technology or whatever, that we would see that go down. That 20% mortality rate has held steady, I mean, as far back as I can figure, right? So it's held steady. And then I told you that when you're taking an alcohol history, the third question I always ask is, when was your last drink, right? So how long, when someone stops drinking, what is the average amount of time that passes from stopping drinking to the development of alcohol withdrawal delirium? About 3 days. Yeah, about 3 days. About 72 hours. So this is really important. When I do APS work, this is super important when I do APS work. So it's quite common that will go into a house and it'll just be a disaster, and it's clear that the client needs to be removed. But they also have they clearly have an alcohol problem. And so what I'm always doing whenever I recommend an emergency removal, I'm always putting the documentation that whatever nursing home this person lands in until the judicial system sorts out the need for guardianship, that nursing home needs to be aware of this alcohol problem and needs to know to monitor for signs of alcohol withdrawal, right? And so 3 days is the average amount of time that passes from last drink until the onset of alcohol withdrawal. And so what alcohol is doing is it slows the brain down in 2 ways. Right? So you have excitatory neurotransmitters and you have inhibitory neurotransmitters. Right? You have an excitatory system in your brain and you have an inhibitory system in your brain. And so would you guess that alcohol stimulates or inhibits the inhibitory system? It stimulates the inhibitory system, right? So you have a system in your brain that inhibits neural flow, okay, neural excitation. So alcohol stimulates your inhibitory system, therefore slowing your brain down even more, right? So there's this chemical in your brain called GABA, and it increases the activity of GABA, and the brain is slowed down even more. Would you guess that alcohol stimulates or inhibits the excitatory system? It inhibits the excitatory system, right? So alcohol is slowing the brain down in 2 ways. It's inhibiting the excitatory system, and it's stimulating the inhibitory system. Does that make sense? So if you're a neuron, and your inhibitory neurons keep getting stimulated, then the response of the neuron is going to be to make less of them. You're going to make less neurotransmitters. You're going to say, look, I keep getting stimulated. I must have too much. I don't need all of this. I'm going to make less inhibitory molecule. If you're a neuron and your excitatory system keeps getting stimulated, the response of the neuron is going to be to make more of it. It's going to say, look, we don't have enough excitation control. We need more of it. Make more. In this case, it's going to be NMDA. Make more of it. And so you're going to be trying to crank out all of this excitatory, and you're going to not be doing any inhibitory. So your brain has slowed down by these 2 ways, and then it's the end of the month, and the check runs out. Right? Your check runs out. End of the month, got to make it 4 days to get that check. And what will happen, so you're out of alcohol, you're out of money, and you're out of alcohol. So then what happens is that you have all of this exposed excitatory tone, and you don't have any inhibitory tone. So you've got all of this brain excitation, you don't have any of the inhibition, and then that's what causes a seizure, right? So this is how alcohol, this is why people will have seizures when they're coming off of alcohol. They have too much excitation and not enough inhibition because of the chronic changes that alcohol has had on the brain. Okay? And then you have a seizure about 2 days later, and then after that, you go into a full alcohol withdrawal delirium. So it's this balance between your excitatory and inhibitory systems in your brain. And so again, 72 hours, the average time of onset for the development of alcohol withdrawal delirium is 72 hours. So another example where we'll see this all the time in the hospital is in trauma accidents, right? So someone will be in a car accident, and they go to surgery, and they have the surgery, and now they're on the post-surgical ward, and things are going okay, but then they haven't had alcohol for 3 days, and now they go into an alcohol withdrawal delirium, right? We'll see patients who've been drinking, and then out of nowhere, they'll have their appendix will flare up, they'll have acute appendicitis, they'll have to have an emergency surgery, they now go without alcohol, and they develop an alcohol withdrawal delirium. And it always happens about 3 days after the last drink, about 3 days after.
So person who drinks a
What's that?
The person who drinks a lot will affect the appendix.
It can affect the appendix, but this would just be secondary. Yeah. So when we're monitoring for symptoms of alcohol withdrawal, there's certain signs and symptoms that we're looking for. So when people start to go into alcohol withdrawal, their blood pressure goes up, their temperature starts to go up, their pulse goes up, and they start to get the tremors, right? So they start to get all this unopposed excitation, and they start to get the tremors. So they have all of these vital sign abnormalities. So when you start to, when I'm telling, if I'm recommending that an APS client be extracted and that they be in a nursing home, I make it very clear that the nursing home needs to monitor their pulse, their blood pressure, their temperature, and monitor for tremors so they can see if this client's going to go into an alcohol withdrawal delirium. And then the other effect of alcohol withdrawal delirium is hallucinations. So people in acute alcohol withdrawal, this isn't the quiet delirium. Now there are people who are quietly delirious. They're just kind of laying in their bed, drifting in and out of consciousness, not just oblivious to the world, but not bothering anybody. So alcohol withdrawal delirium is a hyperactive delirium. Patients in alcohol withdrawal, these are the patients that are pulling out their IVs, they're pulling out the Foley catheter, they're trying to crawl out of bed, they're trying to leave the hospital against medical advice, they're psychotic. It's a very hyperactive delirium. And the earliest signs and symptoms are tremors, blood pressure, and pulse. However, what medication what medication class that elders commonly take would mask these symptoms? What's that? What medication class masks alcohol withdrawal symptoms? So beta blockers, right? So this would be like metoprolol, propranolol. These are medications that elders will take for high blood pressure, or if they've had a heart attack, they'll take these to decrease the oxygen demand on the heart. So if elders are on propranolol or metoprolol or atenolol or anything that rhymes with alol, you have to be really careful with those patients because they're not going to have the tremors, their blood pressure is going to stay down, their pulse is going to stay down as well. You have to be super careful when they're on any hypertensive. So now we can talk about how alcohol withdrawal is treated. So the way that we prevent alcohol withdrawal of delirium is with medications like Valium, Ativan, and Delirium, with benzodiazepines. And so this goes back to what alcohol is doing. So what these medications do, they're analogous to alcohol in that they increase and that they're increasing the inhibitory tone. There's nothing we can do for that excitatory tone, but what we can do is keep the brain on ice. We can keep giving the patients these sedatives, these anxiolytics, these medications that slow the brain down so that as the excitatory system comes back online, they don't have a seizure. So sometimes people will want to know, why would you ever give an alcoholic Ativan? Why would you do that? Why would you treat someone with alcohol dependence with Valium? Isn't that just feeding the fire or feeding their addiction? It has nothing to do with that. It has to do with we're trying to keep that brain in an inhibited state while the excitatory system comes back online so they don't have a seizure and then go into an alcohol-induced delirium. Okay? So the treatment for alcohol delirium is Ativan, Valium, Librium, medications like this that keep the brain slowed down. Okay, so we'll talk a little bit about dementia, alcohol-related dementia. That was a question about this morning. So there's different types of dementia, Korsakoff's dementia, Wernicke syndrome, and then just dementia secondary to alcohol use. Probably I don't know if it's more common, but certainly the more known dementia related to alcohol comes from vitamin deficiencies. So as people start to, when they're alcoholic, when their primary caloric intake is from the alcohol, but they're not taking in the vitamins that they need. And there's these little tiny structures, these right here are called mammillary bodies. It's part of your hypothalamus. Right here, this is the underside of the brain, these little things in green here. These are very sensitive to thiamine deficiency resulting from alcohol. And as the brain becomes depleted of thiamine, in this case of Wernicke's, initially Wernicke's encephalopathy, and then Korsakoff's dementia will set in. And so what we'll see in this type of dementia, the first thing there is ophthalmoplegia, which is a fancy word which means your eyeballs don't move like they should. Okay? So you'll have a patient, and you'll say, okay, I want you to follow my finger. And you'll be moving your finger, and they'll just be staring straight ahead at you. And you say, no, just follow my finger, and you're moving, and they're staring straight ahead at you. No, just follow my finger, and they'll say, I am. Right? And it's like, oh no. Okay, so their eyes, they've lost motor control over their eyes, and they're just staring straight ahead. They'll become confused. Retrograde amnesia means that they'll lose their old memories. They start to develop confabulation. Confabulation is where they just make stuff up, right? So you'll say, well, what did you have for breakfast this morning? Oh, well, I had bacon and eggs and a glass of orange juice. And later on, you find out from the nurse that they had oatmeal and milk, right? So it's not really lying because it's not intentional, but they're just kind of making it up to fill in for the deficits. And then with enough thiamine deficiency and enough of the dementia, it can result in coma and then finally death. What we know about alcohol-related dementia, this is the idea of, people who have kind of quote-unquote just pickled their brain. You'll hear about that. They've pickled their brain. So one of the problems with alcohol is it has to do with the starting and stopping of alcohol. So people have binge alcohol and then they stop alcohol for a while. They binge and they stop. Every time they stop drinking, there's all this free radical damage that happens to their brain that kills off the nerve cells. And so what we know is that people who drink alcohol have lower brain volumes. And so if you just look at, this is just comparing brain volumes of alcohol users. So people who don't drink alcohol, this is the higher up you go here, the more brain volume you have. So abstainers are in this bar here, right? So you can see kind of the range of their brain volume. They have lots of good neural tissue. For people who used to drink, but they don't drink anymore, you can see that they have less brain volume than those who have abstained, right? So even former drinkers have less brain material than those who have never drank. And then those who are drinking lower amounts have less, those who are drinking moderate amounts have less, and those who drink a lot of alcohol have even less brain volume. So alcohol is just eating away the brain is what's happening. It just eats it and eats it and eats it away, and then eventually you have a brain that looks like this, right? So this is a normal 43-year-old's brain, and you can see, the sulci are nicely, pushing up against the cranium. And you can just look at this and appreciate how much smaller this brain is compared to this one, in a 43-year-old person. Right? So this is kind of an extreme example in a 43-year-old, but this wouldn't be an extreme example in an 80-year-old. This is what we would see. So alcohol is just kind of eating away at the brain. And that comes from the start-stop and the oxidative cell death, the free radical damage. So, man, it's like 3:35. Okay, so I'll open up to questions about alcohol. Yeah.
When you go and do your home visit to do an evaluation, let's say that the individual that you visit has been an alcoholic maybe for 40 years and still continues to drink. So how would you do that assessment?
Yeah, so the question is that when we're doing these home visits, a person may have been an alcoholic for like 40 years, and so how do we do these assessments? How do we do these capacity assessments with alcoholics? Because clearly alcohol would impair their capacity, but the judge wants to know, well, of course alcohol impairs their capacity, but how is their capacity when they're not drinking? And then it becomes this circular argument, right? It's like, well, they're incapacitated because they're drinking. Well, are they incapacitated when they're not drinking? Well, we don't know because they're always drinking. Okay, so are they incapacitated when they're not drinking? Well, we don't know because they're always, right? And it just becomes kind of this very circular argument, right? So, now I'll tell you my take on this. I'll tell you what I do. I don't know if it's right or wrong. I really don't, but I'll tell you what I do. So, the Texas law, what Texas law says is that a person does not have capacity if because of a physical or mental condition they are substantially unable to provide food, clothing, or shelter, care for their health care needs, or manage their finances, right? That's the Texas law. So then it comes down to, well, they have to have the disability, and they have to have, in this case, a mental condition. Do you think that alcohol dependence is a mental condition? Yeah, I do take it right. Okay, so in my mind, they have a mental condition. The mental condition is alcohol dependence. Because of the alcohol dependence, they're not attending to these self-care activities, and because of that, they meet the definition for incapacity, and then I say that they don't have capacity. And then I put it on the judge, essentially. So then the judge is going to have to decide, again, how much risk is society willing to tolerate, right? It's up to the judge to decide. And so what can happen, and what has happened, is that people will say, okay, well, this person doesn't have capacity now. The judge is going to order some type of treatment program for them. And then the judge will order that the capacity assessment be repeated however many days after they've completed their alcohol treatment program. And so I've seen where that's happened before, for example. So I don't know that that's a good answer, but I mean, that's the best I can do. It's a good question. Alcohol question. Really? Hey, I ran out of batteries. We gotta be done if we're out of batteries. Thank you, everybody, for your time.
We ran out of batteries. I think it was an excellent presentation. Hopefully you all picked something up from it. We are now going to be holding our last drawing, so please hold on. Number 117. Are you still here? 117. Now this is for the subway. I don't know how many gift cards are in there. There's more than one. Now we're going to do the big one. This is for the iPad mini. So everybody definitely wants to have their number ready, right? Number 045, 45. We have a number. This is from BNVD. They have contributed an iPad mini as our major door prize. I want to thank everybody for coming today. I did want to announce that next week, the Area Agency on Aging will hold their senior expo on the 21st. Don't leave yet. I want to get a picture. You want to get a picture? Of our grand prize winner. We always want to record one big prize. Thank you all for coming today. Again, Senior Expo at the Civic Center next Wednesday, a free event. If you have any seniors we should bring to the event, free admission, there'll be different exhibitors there. The time, you're given the sheet of paper that has the times, I believe it starts at 9 and 6. Through the day, 9 to 4. Thank you again.
Okay, before you leave, and you have thank you that you want for this conference. Here are the rules. Everyone who attended today will get some sort of certificate. If you don't want ECU, you will receive a certificate of attendance to show your employer that show proof that you were attended today and you were here. If you want CEU, go ahead and turn it to me up here in front. I will not take cash or check. It has to be done in the front. You have paid already. But this is what's going to happen. We give you the form. I will email you an evaluation. Once you finish that evaluation, I will email you a certificate for you to print out. You pay up front. If you haven't paid so far, you have to pay up front. The payment right now is $35.
Out in the West Texas town of El Paso, I fell in love with a Mexican girl. Nighttime would find me in Rose's cantina. Music would play and Felina would whirl. Blacker than night were the eyes of Felina, wicked and evil while casting a spell. My love was deep for this Mexican maid. I was in love, but in vain I could tell.